Why don't we go ahead and get started? 7 a.m. It's 2 minutes after, actually. Welcome to the 19th annual Marvin Pomerantz Visiting Professorship. This year we are honored to have Sunil Singhal from the University of Pennsylvania here with us. We'll talk about Sunil here in just a second. I want to say a couple of words about Dr. Pomerantz. Marv is a native New Yorker. And that, to be sure, never left him. He went undergrad at Colgate, med school at the University of Rochester, and then did all of his surgical training at Duke under David Sabiston. After he finished, he was recruited out to Denver by Ben Eisman to initiate the cardiac surgical program at Denver Health, then Denver General. He was quite successful, but in the late 70s, moved into private practice and spent the next 15 or so years in private practice here in Denver, and also was quite successful in that endeavor. But in the early 1990s, Dr. Grover persuaded Marv to come back to the University of Colorado. Dr. Grover and Dr. Pomerantz were longtime friends from their time at Duke. And so Marv came back to run general thoracic surgery at the university. He was enormously successful. Few people can say that you are the world's expert in something, but Dr. Pomerantz was the world's expert, and really still is, in the surgical treatment of mycobacterial disease, particularly tuberculosis. He had a very astounding career. He was president of the Western Thoracic. He was on the American Board of Thoracic Surgery and actually served as its chair. He signed my certificate. He retired in 2004. Marv is a wonderful individual. He's a great athlete. He was the Colorado tennis champ when he was here. He was at one time a part owner of the Denver Nuggets. And Marv loved to play golf. And for many years, Doctors Cleveland, Fullerton, and Mitchell were with Marv on a team at the Western Thoracic Golf Tournament. And I don't think I've ever seen Marv quite as happy as the year we won. And everybody in the room knows pressure, but I'll tell you something, you don't know what it's like to have Dr. Pomerantz stand behind you after you tee off and say, that's not what we needed. Yeah. All right. So Marv is retired. He lives in Tucson with his wife, Peggy, who's the real life of the family. Marv is going to turn 91 in June. We wish he were here. If he were here, he'd be extremely pleased that we invited Dr. Singhal to be our visiting professor. Sunil is the William Mall Measy Professor of Surgery at the University of Pennsylvania. He's the chief of the Division of Thoracic Surgery, the vice chair for translational research for the department, and he is the director of the Center for Precision Surgery at the Abramson Cancer Center at Penn. Sunil went undergrad at Dartmouth and then went to med school at the University of Pennsylvania. He did his general surgery at Johns Hopkins, where he rubbed shoulders with Rob McGee and Dr. Schulich. He then came back to University of Pennsylvania, where he did his CT fellowship and joined the faculty there in 2008. So Sunil is really the quintessential triple threat, I got to tell you. You hear that a lot, but he's the real deal. He's an outstanding surgeon. He's won numerous awards, and I have seen him operate in person, and he's the real deal in that department. He's a terrific educator, no question about that, working at Penn. And then he just simply has an incredible research experience, which we are going to hear about, I believe, today. He's been continuously funded by the NIH since he joined the faculty in 2008. He has over 300 publications to his credit. And to me personally, I think his research endeavors are so important because they affect thoracic surgeons on a daily basis. And you'll hear more about it. His efforts have led to things that we use in the OR every week here. So, Dr. Singhal, thank you so much for coming. We're eager to hear your talk. It's entitled Intraoperative Molecular Imaging of Lung Cancer.
Thank you very much. Thanks for that very generous introduction. I appreciate it. Thank you. And actually so just to correct, actually the world's expert in MOT surgery now is actually you, I would say. And I would say people around the world still probably call you when it comes to mycobacterial infections. So when you talk about world's experts, I think you've replaced Palmer, and so that's congratulations. And actually for everything Thoracic's done here, I also want to do a special appreciation for Rich Schulich. I did my first right hemicolectomy with him, my first Whipple with him, my first open J tube with him, and was chief resident with him for a couple of months. And that was a tremendous experience, both in my training and growing up in maturity, as well as my co-resident, Rob McGee, when I were good friends through our years at Hopkins. So I appreciate that. It's good to be here, and I'm really honored by this invitation. I want to talk to you today a little bit about intraoperative molecular imaging. This is very applicable to everything what we do in this room, for many of you, what you do in this room. So I just want to talk to you very broadly about cancer surgery and start off there. So to cancer surgeons in the room, what does every cancer surgeon want for their patient, every cancer patient? What are you thinking of? You want two things. One, you want to get the entire cancer out, and you also want to stage the patient. You want to make sure you identify every lymph node that has cancer cells in it. So if we take a look, very broad look at cancer, and ask yourself, what are the pivotal things that have happened in cancer that have altered surgical outcomes? By surgical outcomes, I mean the ability to cure, truly cure. So the first thing is, if you go back to Egypt, the concept was that you should remove a cancer by cautery. First operation ever recorded was a breast cancer operation. So just take off the breast. 1,500 years later in France, Ambrose suggested that it's not enough to take out the cancer, but you should take the lymph nodes. And there was some value in that. And now fast forward to 1846, anesthesia. So why is anesthesia important? It actually there were two major pivots in cancer surgery. Anesthesia was one of them because at the time, the point of cancer operations was to go as fast as possible. You didn't care about margins. You just wanted to remove the cancer. When anesthesia came, surgeons actually started to slow down. So they started to think about the margins palpating the tumor. And then 1867, there was a dramatic increase in cancer surgery in the world. Why? Prior to that, when you had cancer, you had the risk going to the OR and dying of an infection. But when antisepsis came, all of a sudden the field took off. It's not that long ago that cancer surgery really started to grow as a profession. Now, fast forward 1971, I would argue CAT scans altered the field. At the time, you would do an X-ray, you would do belly films, you would make physical exams, you'd go to the OR, but it was really CAT scans that people started to do preclinical staging of patients before they went to the OR. And then I would argue in 2001 was really a pivotal point, especially in the chest for PET scans. I think without PET scans, the ability to stage people even better. So I would say nothing has changed since then. When you think about truly what changes the surgical outcome, I'm not talking about laparoscopy or robotics or all these things that decrease morbidity, but what truly improves the outcome from surgery. Now, surgery is getting much tougher for us because even though 65% of the time we're the only ones to cure the patients, 40% of the time we still have local recurrences, but there's a lot of challenges. Radiology is picking up tumors that are smaller and smaller. We've lost the ability to do manual palpation, especially in thoracic when you're doing a GGO, when you're doing robotics, or you're doing some really big segments for small GGOs, you don't know where the margins are. And then the other thing is, sure, this is true in other specialties, but in thoracic, all our patients are getting chemo up front, immunotherapy. We're left behind with scar. We don't know what the borders are. So the field is getting harder and harder. And this is the perfect time that surgeons need to go out and innovate. So I looked at this broadly. What are the big challenges across all surgical oncology specialties? So if you look at it, positive margins. It's the dreaded complication or risk that a surgeon takes, having a positive margin, whether you're doing an IPMN in the head of the pancreas or a head and neck, synchronous lesions. When you have DCIS and you have skip lesions, or you're doing a prostate cancer and you have seeding throughout the prostate, locating small nodules, GGOs, colon polyps, which ones are cancerous, which ones are not. Frozen section, I don't know whether the challenges are here, but we have a tremendous amount of challenges of getting reliable frozen sections at Penn. Positive lymph nodes. I mean, we still do these massive lymphadenectomies, put people through lymphedema. And we still have problems with injuring adjacent structures. So, you know, people say, well, what are the problems left? There's still a lot of problems in cancer surgery. And why do we have these problems? Because when we go to the OR, we as surgeons still use two tools. We use our hands and we use our eyes. We're still using the same two tools we've always used. So I'm going to give everybody this case, and everybody has got to participate in this. In order to make this fun, you really do need to participate in this quiz. All right, so I'm going to give everybody a case. You don't need to be a surgeon to make some decisions on this. 60-year-old comes in, 9mm left upper lobe lung nodule, heart solid, GGO, very straightforward. They had a prior right lower lobe 15 years ago. They wanted this out. They were nervous, and they were going to do, I was just going to do a wedge. I mean, it's a 9mm nodule, wasn't very solid. I'll show you the picture. It's okay. It's something I think a wedge is sufficient. I've been following it from 6 to 9, and I thought that was going to be sufficient. I'll show you the CAT scan. Look at this CAT scan very carefully, especially the front row of thoracic surgeons, all three. I want you to make sure you appreciate this scan is clear. There's only the 9mm nodule. No other nodules. Clear lung, stage 1A, should be curable resection. I'm going to show you that entire lobe. And finish up that left upper lobe. Look carefully. All our patients get 1mm fine cut chest CTs. So here we are. We're in the OR. Question 1. Where is this nodule? You have to write it down, vote, whatever you want to do. 1, 2, 3, or 4. Where is this nodule? Right, 1, dark spot. 2, what is it? Is it cancer? Is it not cancer? And if you want extra credit, how confident are you that this is cancer? Question 3, I'm about to cut it out. I'm going to use my stapler. I got it in. Let's pretend I have the nodule. I have it in the ring forceps. A surgeon is about to make a decision. We think about this. That's one of the things that defines surgeons, is their ability to make a decision. I'm about to make this decision. Where do you make the cut? 1, 2, 3, or 4? Everybody take a vote. Everybody's going to say, well, just do 4. Do more. Do more. Is 4 the right answer? And did I get it all? So now I cut it out. I'm on the back table. I got to think, do I get it frozen? Do I waste 25 minutes? I got another room running. I can't even trust the frozen section. It might be the GU pathologist down there today. I don't know. What do I do? And so 15% of people who undergo that operation will develop a local recurrence. That's horrendous as thoracic surgeons. And not only that, if you screw up and you do get a local recurrence, it would have been better you never touched that patient, because the 5-year survival is worse. Because a lot of times you miss these nodules. On follow-up CAT scans, you think it's scar, you think it's hematoma, they get ignored, they metastasize. And so this is a surgical problem. This is what we're out to cure. And so something happened to me that completely changed my life. I was a fellow training, and I had done a case with Larry Kaiser, who was at the time the attending, and we did it on a Penn student. It was a 23-year-old. She was a never smoker. She was a runner, and she got lung cancer. So we went in, we took it out. It was a straightforward right upper lobe. I was the fellow on the case. Afterwards, I remember we told the family, your daughter's cured. Everybody was relieved. We were very happy. 3 months later, she comes back for her routine scan. We put the scan up. It was back in paper films, actually. So we put up, and there are metastases everywhere, both lungs. Just big, these cannonball tumors. 3 months, and I was completely floored. I was still in that point in my training where I was like, wow, this is unbelievable. And I remember how sad I was that this woman had recurred. And that night, I go home, And I laid down next to my, we just had a baby girl, and I laid down next to her. She was in the crib, and I was just wanted to, and I looked up and I saw these stars. And my wife had put these little fluorescent stickies on the ceiling. And I said to myself, oh, God, I wish we could have made those cancer cells glow. Because if those cancer cells had been glowing when we did the operation, we never would have missed those metastases. And that was the birth of the idea. So I spent the next 16 years of my life trying to make tumors glow. And I'm going to tell you that story and tell you about the applications to everything that cancer surgeons can do in any specialty. So this was the thesis of intraoperative molecular imaging, IMI, that IMI doing cancer surgery can improve surgical outcomes. And this is very important, that word surgical outcomes. We're not here to do fancy tricks in the OR. We are here to truly improve cancer outcomes, survival, and decision-making. Decision-making is very difficult for surgeons. We develop intuitions, and that's why experienced surgeons are so important, because their intuition theoretically has matured. But what about when you're starting out? What happens if we can make decision-making better at all levels in the OR? And so we want to improve surgical outcomes, and can we do a better cancer operation? So what is IMI? We need two things. We need a contrast agent that we can inject in the patient, and we need a camera. So we need to be able to get a tumor to glow, and then we need to be able to see it. And so what we developed is fluorescent contrast agents injected into patients before surgery. Now, people have known about contrast agents for a long time. Methylene blue, ICG. But what we did was we changed the paradigm in the sense that we developed the first targeted fluorescent contrast agent. So that was the key. We started targeting contrast agents, ICG, fluorescein, by attaching it to molecules. Now, when we started, there was a numerous number of things we were thinking about, and there's no way we can go through all of this. But I think what I wanted to just highlight is a few things is in the process, and the reason this took 16 years, is we made some very good decisions, but we also made some very bad decisions. And I'll tell you a little bit about that story. So one of the major epiphanies to me was that when we do image-guided surgery, when we do fluorescence-guided surgery or intraoperative molecular imaging, we care about sensitivity. Because people will say, well, you know, people have been trying to target tumors forever. I mean, that's what, if you're a drug company and somebody's got a brain cancer, you want to make sure you give a drug that kills maybe 50% of the brain cancer cells. But you don't want to kill a normal brain cell. And what we do, we think very differently. I want to make sure when we give a tracer and it's going to a brain cancer, every single brain cancer cell glows, every single one. If the liver glows and the kidney glows, I don't care. I'm not operating down there. So this was a major paradigm. It actually made our life a lot easier, because then we can start thinking of fluorophores. We can start thinking about fluorophores that can go to tumors that are safe, that can wash out in the kidney, that can wash out in the liver, and we don't care, because we don't have to worry about toxicity. And we wanted something very bright, something so bright that this is a pitch dark room, these fluorophores really shine across the room. And we wanted something that could survive the harsh conditions that exist in tumors, low pH, hypoxia. And another key pivot point that really probably was one of the best decisions we made was we wanted something very, very small. So there are, for people who know the field, there's about 6 other companies out there that are developing tracers that go to tumors. But they're using antibodies, these gigantic antibodies. There's 150 kilodaltons. They take 5 days to circulate. They get stuck in the liver, and they're extremely expensive. Whereas we decided very early on, we were going to go with a very small molecule. So this is just a comparison of some of the fluorescent particles that we used. The advantage is that we can give our tracers just hours before surgery. They wash out, they're completely safe, and you can drink them by the gallons. The other thing about these molecules is that they're extraordinarily cheap. Small molecules are basic chemistry. We can make these things for a penny a gram. Whereas if you're doing antibodies, we're talking about $50,000 per gram. of antibodies these days. So, because they're biologics. So this was really probably the best decision we made very early on. So we started looking at circulating time. We made it so that we could give the tracers faster and faster. We have a lot of patients that come from all over. We didn't want them to make 2 trips. So we didn't want people to come 5 days before, get the tracer, go home, and then come back for the surgery. So one of the other aspects of this was when we started, we were working in the visible wavelength. So we wanted to get to the point that we could give tracers. And so people don't realize this, before Cytolux, for 6-7 years, I worked on a tracer that was visible. You didn't need a camera. That was a major mistake. It actually set us back for almost half a decade, because at the time, those tracers would autofluorescent blood. So if you, as you were doing the case and you were spilling blood, you'd see the smear. And so we were completely, we actually get up to a phase 2 clinical trial before we had to abandon the study. So it was some of the best decisions to do fluorescence, but one of the worst decisions to do it in the visible wavelength. And it's only later that we switched to near infrared. So this was Cytolux. And I know there's a couple of representatives from Cytolux who came out with Cytolux, which is the FDA-approved molecule now. This was in the near infrared. We made one more big mistake. And I hope the Stryker reps cover their ears for a second, but actually I do think this is going to be the death knell for Cytolux. And I think that the next generation is coming. So what we did was, this is ICG. And so ICG, everybody knows, you probably have a scope here, whether it's Stryker, Olympus, or Firefly, you can just use ICG. Well, we made a slight modification. We thought, oh, what's the big deal? You make this modification. We moved the emission from 802 to 796. No big deal? Big deal. All these cameras, their filter is at 800 across the board. They all get it from the same vendor in the United States. They all make it at 800. You can't see Cytolux unless you get a specialized camera. There's only one camera out there. It's the Stryker 1788, which you have. But if you don't have the Stryker 1788 around this country, you can't use this product. So now we're going back and we're developing new products. But this was a major error when we started this process. So just that little molecular change. Our first camera, the first fluorescent camera for imaging, was this spectrometer we had in the OR. We just hooked it up to a little light wand and sterilized it, and we saw tumors. We eventually moved to optical. This was the first camera that we built. It was just simply some pieces from Home Depot and a heat sink. And this was the first fluorescent. And then we eventually got to the 5th camera, which is a combination of a near infrared camera with a color camera. And this is, I'm just going to give you a quick example. We used to put this on a periscope, and we'd bring the periscope down into the patient in order to do these cases. We had to do them open. We didn't have a laparoscope at the time. And then when we did the surgery, we could see both the white light and the tumor fluorescing. And this was the very first case we did. And here you can see what it looks like. This was the left upper lobe. And you can see where the tumor is fluorescing. It's obviously the technology has moved far away, but this was the very first fluorescence guided operation in the US targeted. And here you can see what it looks like on the back table. So notice it had to be black and white because it was in the fluorescein, which was in the visible wavelength. We eventually developed thoracoscopes and now bronchoscopes to do this technology. So let's fast forward now. So where are we now? So now we have 6 tracers. There's 6 tracers available. I'm going to tell you about tumor glow for sure, and I want to tell you about Cytolux, the folate receptor. If we have time, we'll talk about the pH-activated probe and the cathepsin, but if not, we'll skip that. So let me tell you about tumor glow. So the beginning of this was all tumor glow. At the time, I was reading a paper from 1988, cancer research from Japan, and people were talking about nanoparticles. It was the hottest thing when I came out of my fellowship, and nanoparticles are very unique because tumors, as you know, secrete a lot of VEGF. They make new arteries, they make new veins, but they don't make lymphatics. So tumors don't have lymphatics. They get lymphatics around tumors. There's a pressure gradient within tumors, and therefore that 10 millimeter pressure difference is enough for nanoparticles to get trapped. It's the basis of nanoparticle technology. So we said, well, why can't we do this for fluorescent probes? And so we were working on this for years, and we could not get nanoparticle fluorescent probes to stick in tumors. And we were working ICG, which is a classic nanoparticle. And then this day happened where this is a tech in the lab, and he had done an experiment. We were giving the tracers. As you know, if you open up the label of ICG, it says half-life 12 minutes. We'd give it, we try to make tumors glow. It didn't work. We were doing all sorts of changes of albumin products and what people were talking about in Japan at the time. And then one day he did this experiment. He gave the ICG, and then he didn't kill the mouse. He had to get to a birthday party for his girlfriend. And he didn't kill the mouse. He left the mouse and comes back the next day. Tumors glowing. And we made a major seminal contribution to the field of nanotechnology. There's a washout time. There's a tremendous washout time. No one even knew, but the washout time is almost 24 hours. This is why you give Cytolux probably the day before. You got to give that washout time. Otherwise, you get too much background. You probably have experienced that when you get background. And so the key is the EPR effect kicks in after 24 hours. And that was the birth of tumor glow. And so I'll give you a quick example. This is a 39-year-old. I'm going to show you the CAT scan, a lot of CAT scans, because I want to prove to the audience that we're not making this up. This patient has a singular lingular lesion, tiny lesion, and you get in, this is the ring forceps. The ring forceps, for anybody who hasn't counted, is a 1 centimeter across, all the way across. Not easy to see that cancer. You turn on the fluorescence camera, and you can immediately notice it. And this, again, this patient has singular lingular nodule, and we take it out. And before we close, we always look around for any other additional cancers. I know I played that CAT scan pretty fast, but here we're looking. And there we found a 2 millimeter MET, another 2 millimeter MET for metastatic sarcoma. So we did a couple of clinical trials, 30 patients. We knew these 30 patients had 53 lesions. 10 got thoracotomy. So they got their hands and their eyes. So the surgeon used their hands and their eyes. And the surgeon found 7 additional cancers. And then when the surgeon did that, so no hands, the surgeon found 20 additional cancers, which makes sense. So then we turned on the camera. And we turned on the camera, in the hands and eyes group, the surgeon found 3 additional cancers. So even more than just hands and eyes. And when they used the camera alone, they found 21 additional cancers. That's a lot for a metastatectomy. So people said to me, and I got criticized a couple times at AATS, who cares? It's a metastatectomy. So you're finding a couple 2 millimeter lesions. Well, we did this for several years. We got 5, 6, 7 years into this, and we started discovering our patients were actually living longer. Like, how is it possible? You're doing a metastatectomy on one side, you're picking up a 2 millimeter nodule. You know there's got to be lesions on the other side. There's got to be. And, Sir Folio, in the meantime, is writing, he does all these by sternotomy. He wants to feel both out. So we went back, and this resident was convinced about this, and he went back and he did this, initially this 5-year survival. We have another one coming out because we've accumulated more patients since. And we actually found that patients were living longer. And I still didn't believe the data. So I had him go back and look at all the data to see why people live longer with fluorescence-guided surgery. And there were 2 things that were happening. The first, so when we found people, and say an oncologist sent the patient to me and says, take out this, a 1 centimeter lesion, and we came back and we said we found 2 more, the medical oncologists were changing their practice. First, they were doing more surveillance. Instead of doing every 6 months, they switched to every 4 months. So we changed our decisions. Their decision-making was changed by our decisions. The second thing is they were preemptively treating these people who they never would have treated. So they were catching them with minimal residual disease. I think that's why we suspect these people were living longer. So let me talk about Cytolux now, which is what the FDA-approved molecule. So I'm going to switch topics to this other tracer. So lung cancer uses a lot of folate. As a matter of fact, it uses 10 to the 5th more folate than normal lung epithelium. Plain old folate, the stuff you eat in eggs. And at the time, there was a chemist from Purdue. He had developed folate fluorescein. And I don't know, Richie, Dr. Schulich may know this. This was being used for immunotherapy for renal cell carcinoma. And it went all the way to phase 3 clinical trial. And he was giving folate fluorescein for renal cell carcinoma. And then he was following it with an antibody to fluorescein, so anti-fluorescein chemotherapy. And went to phase 3 and then eventually abandoned, and the company was disbanded because there was no improvement in survival. So there was no toxicity, but no improvement in survival. I heard about this and I said, oh, this is perfect. We should start doing image-guided surgery. So I reached out to him, we got his molecule, and we did the first tracer, which was the folate, which I told you about. And then what happened was I took our tumor glow and combined it with his folate, and we switched into near infrared. So he had been working on the folate fluorescein, I'd been working on tumor glow. We combined the tracers, we got Cytolux. And that's what's in humans now. So what is it? It's really simple. It's folate linked up to ICG, basically, or a variant. And it's very specific for lung cancer. And it gets internalized, which is even nicer because you can let it wash out at the back. And the longer you wait, the better. Even waiting 2 days is even better than 1 day because it just washes out. And here you can just see what that looks like in the lab. So we started doing multiple clinical trials, clinical studies. We published this on mouse studies. We were able to show it didn't matter what kind of lung cancer, and actually didn't even matter your folate receptor expression. You could have only 10% of the cells express folate receptor and the cancer would glow because it's 10 to the 5th higher expression. It's just so much vastly bigger. So people say, well, you have to have folate receptor. Actually, really, everybody has folate receptor on their lung, adenocarcinomas, everybody. And it can last to 5 days. The binding is very specific and the biodistribution is favorable, and I'll skip some of this for time. And then we did a number of preclinical studies, and we were asking, like, how small can we see? So in laboratory conditions, we can get down to 7 millimeters, 0.7 millimeters. So not less than 1 millimeter, 0.7 millimeters. And here we would do experiments where we'd take mice, we would resect them, and here we would use spectroscopy. We could detect 1,000 cancer cells in the wound bed after the operation. So with our spectroscope, not with the camera. And here is our modern day camera now. So this was the Medtronic, and actually now there's a Stryker. Sorry, I don't have the Stryker images, but the first camera we built was the Vision Sense, which eventually we sold to Medtronic. And here you can see the quality. So there were many challenges, of course. You would say, well, it's a mouse. Anybody can cure a tumor in a mouse. Tumors are encapsulated. So we went on to dogs. We had a tremendous amount of lung cancer in dogs in Philadelphia. A lot of the owners smoke, and because of that, the dogs get secondhand smoke exposure, and they get lung cancer. And so this is David Holt. He's the chief of surgery at the veterinary school. And the beautiful thing about this model was the dogs really usually don't get chemo and radiation afterwards. So if the surgeon has a positive margin, they recur, they die. And here's an example, one of the very first cases we did in a dog. Here you can see this lung cancer in the dog. And here you can see one of our earlier cameras. There's a lot of, actually this doesn't come off great, but you can see some of the borders of the tumor, and there's really no autofluorescence, which is nice because we eliminated the blood issue, the leakage from the blood. And that was another major step. And here you can see what this tumor looks like. I don't know if this projects well. We get better images coming up. So we went to phase 1 clinical trial. At this point, we were ready for humans. We had 30 patients. It was a single arm study. We tested 2 doses. We did several cameras, including our camera that we had built, the Medtronic version, and other cameras. And here's an example. On the left, you can see that this patient has a right middle lobe lesion, very obvious there. And this is one of our very first cases that was ever done with a Cytolux or palbociclib. And here you can see, it's not very clear where that lung cancer is. You can begin to speculate, you see a little bit of a brown spot here, but you don't really need to be a thoracic surgeon anymore to do what we do. It's pretty straightforward. These cancers light up across the room, and you can identify them pretty readily. You know where you put your stapler. And we quantify the fluorescence, and we're using artificial intelligence now to quantify this and compare that to the SUV value on PET to make predictive values of whether it's cancerous or not. And we always use pathology as the gold standard. So what were the lessons from the phase 1 clinical trial? The patients that we make the biggest impact are people who have small tumors, less than 1 centimeter, because if it's greater than 1 centimeter, you're probably going to see it on a CAT scan. You're going to know it's there before you get in. And the other patient population that we get an advantage is people who are this. It's very close to the surface because the Achilles heel of this is depth. This is optical. There's no radiation. You can do it to kids, you can do pregnant people. You don't have to wear lead. You just give the dye, you look at it. And so if it's really deep, you're not going to see much deeper than 2 centimeters in a lung, which is pretty good because after 2 centimeters, you're probably doing a lobe anyway. But so 2 centimeters is pretty good. So we went to phase 2 clinical trial. This was a multi-institutional study. It centers around the country, MD Anderson, Cleveland Clinic. The criteria was very straightforward. Everybody had to have a 1 millimeter fine cut chest CT within 6 weeks. And there were 3 times where you would call this a clinically significant event, CSE. That's our endpoint. So in all these clinical trials, we've done 16 clinical trials. The endpoint is called a CSE, clinical significant event, and it has one of 3 criteria. 1, how often we find an additional cancer that the radiologist or the surgeon did not see on the preoperative CAT scan. So on the form, the case report, I know you're going to participate in some of these clinical trials, you have to record what you see on the CAT scan. So if there's something that comes out that wasn't on that scan, that's a positive patient. 2, how often you can't find the cancer. So you're doing a GGO, and you have to make a decision whether to do a completion lobectomy or do a thoracotomy. And then if you turn on the camera and you spare the patient a bigger operation, that's considered an event. And 3, how often you do the case, you think you've completely resected it, both you and the resident have to sign off that you think you've completely removed the cancer. You turn on the camera and you have a positive margin. So that was the study, and we've done this over and over and over. And so a localization, let me just give you an example. This is a 73-year-old, very nervous woman. She wanted this out. It's 1.2 centimeter GGO. This is a reasonable lesion to resect, maybe a posterior segment. And here you go in, and where do you begin to even look for this lesion? I mean, what are you going to do? Just a really big wedge? Do you do a segment? Do you just do the right upper lobe? She's got good PFTs. So here, now, there's no guessing. We take the guessing out of this. You can really begin to focus on where you put your stapler and making sure you get this entire thing out. Margins, I'll give you another example. This is a case I did, very small lesion. And this woman wanted this out. I was just going to do a wedge. And I didn't, the other thing that's important is the camera is not, you're not allowed to look at the camera in the studies. In the studies, you have to turn it towards the tech because you're trying to be blinded. So I want you to watch this study. So here you can see the lesion. Seems very clear, very easy. This should be a slam dunk, no problem. Try to feel it. It's really hard to feel these GGOs. And then I come in for my resection. And then you're going to see a low reflection off the stapler, so ignore that for a second. And I start firing. And I want you to watch this very carefully now. So as I do this, and I finish my resection, look what happens. The cancer slipped out. I didn't see this. I think I had the lesion. It actually slipped out. I had given the patient a positive margin. I think this happens more than you think. I think this is the problem why we have a 15 to 20% positive margin rate. I think we get overly confident surgeons, just kind of like what general surgeons do when they think they're taking the gallbladder, the cystic duct, taking the common bile duct. It's just a overconfidence in our visualization. And so when we took it out and I looked on the back table before I closed the patient, I had a positive margin there. And so before I closed, I was able to go back and do a wider resection. So this would have been considered a clinically significant event because I had a positive margin. And true enough, on the frozen, on the permanent, this was a positive margin on that initial wedge. And 3 is synchronous lesion. So this patient, she comes in, sees a stage 3A. She had an 8 centimeter left upper lobe lesion. She got pre-op chemo radiation. This is before chemo IO. And here you can see she has a pretty big lesion that I was going in for. And actually, because she had chemo radiation, I was going to do this through a posterior lateral. Please look at the left lower lobe. Left lower lobe looks clean, no mets. Very, very clean looking scan. And here I am. I'm just going to orient you to my view. This is the left upper lobe. This is the fissure. This is the left lower lobe. And here you go. As soon as we went in, first thing we saw was these mets. You can see them right there fluorescing. And true enough, these were mets. So this was a patient who had chemo, had radiation, had gotten all the right therapies, and that still had metastases that we didn't know about. So I'll skip a little bit of this. So we did a phase 2 clinical trial. The results were even better than we expected. So in 29 cases, we had, so 26%, 1 out of every 4 cases, we found a clinically significant event, something that altered the behavior of the surgeon. So at that point, we went to phase 3. This was a randomized clinical trial. Everybody got the tracer. The FDA wanted everybody to get the fluorescent probe so that the surgeon didn't know what was going to happen. And then you did the operation. And then at the end of the operation, when you and the resident agreed you had done the best operation possible, you opened the envelope and you were told whether or not you could use the camera. So that was the design of the study. And that way you were completely unbiased. And these were the sites. It was a multi-institutional study. Actually, Colorado was in it, but we just didn't we didn't get accrual at the time. We went on. It was all of major centers were involved: Cleveland Clinic, Mayo, and Pittsburgh, UVA, Michigan. And this was again, there's a lot of criticism. Remember at the time, I don't know if you remember at the ATS, people were like, "Well, it doesn't make sense." You get a kick out of this. Duca D'Amico stood up and said, "I never get a positive margin, ever get a positive margin." And so we presented this study. And like I said, it was a randomized clinical trial, same endpoints, localization, synchronous lesions, close margin. 54% of the time, 1 out of every 2 cases in this randomized clinical trial, the surgeon altered their behavior after turning on the camera. Think about decision-making and how many cancer operations, say you do 10 cancer operations in a week. Imagine half of them, you would have done something differently if you had given the patient a targeted fluorescent contrast agent. Whether you're doing a Whipple and you're just moving the margin a little bit further away or a little bit less, whether you're doing a colon resection and you're noticing a lymph node that you should actually have taken out, if you're doing a breast resection and you go to the armpit and you're like, I think I don't need to give this patient lymphedema. Those lymph nodes are clean. So localization, 19% of the time we had benefits of localization. This is a traditional white view, not easy to see what the lesion is. You turn on the camera. So that's the localization concept. Synchronous lesions, this is a patient comes in for a right upper lobe. Trust me, the right lower lobe was clean. And here you go. Found the met in the right lower lobe. The interesting part of this study, when we unblinded to the results, 8 out of the 9 times, the cancer, the met, or actually I should say synchronous cancer, was a 1A, was always in a lobe other than the one we were going to take out. So this is the patient that you would have continued to follow. 4 or 5 years later, they come back and they have another lesion. And then we had positive margins. And here you can see, this is what a clean margin looks like. You're very comfortable looking here at the distance. You have a ruler there so you can kind of eyeball your margin. And this is what a positive margin looks like. You can see the staple line and you can see cancer right up to the staple line. And this is also always validated by pathology. So we were FDA approved in December 22. We've had a little bit of slow adoption because of the camera problem that I mentioned to the audience. So I'm going to skip all the cathepsin stuff. The reason I'm just going to mention one word, the cathepsin now is going to do 2 things that we can't do with Cytolux. First, it can do any lung cancer. So far, we're only doing lung adenocarcinomas. This can do any lung pathology. So squamous, carcinoids. The other thing is it works on the robot. So that's going to be a huge bonus for us so that we can start doing robotic lobectomies. All right. So I want to skip now to just finish up on a couple points. So come back to this case. Everybody voted. Everybody's going to have to make some decisions. And remember your answers. Remember, 60-year-old, 9mm left upper lobe nodule, plan, wedge, and lymph nodes. Where's the lesion? I said 1, 2, 3, or 4. All right. Now, you don't need to be a thoracic surgeon to make these decisions. And I'm starting to go in. So it's obviously in 0.4. It was not this brown spot or this brown spot. So location 4. Was it cancer or not cancer? You don't need a frozen. It's fluorescing. It's cancer. You know it's cancer. How confident are you? Based on the CAT scan, how confident are you? Pretty confident. How confident are you now? You're like 100% confident. As a matter of fact, we now have gone into artificial intelligence. So we're using the amount of fluorescence, combining it with the SUV value on the PET scan, and together we actually give you a predictive model. As you do the operation, before you even taking it out, we're giving you 99.5% confidence. We have 2 models. This is 99.5% confident. You have lung cancer, proceed, don't get a frozen section. Where do you put the stapler? Everybody says just do more, take more. All right, so here we are, going in. Left is the white light that you typically would do. I want you to look here. We turn on the camera. The cancer's up here. I showed you the CAT scan. This patient had another synchronous lung cancer. You would not have, you didn't see it anywhere else. So what's the right answer? 4 would have been the absolute wrong answer. You would have cut across the cancer, or even if you didn't cut across it, I guarantee you 4 to 6 months later on the CAT scan, they would have said, that's a staple line hematoma. You can ignore that. You would have sat on that and sat on that and sat on that. And in fact, that would have been another lung cancer. So ideally, you would have done further than all of them, but definitely not 4. So we actually now have an AI algorithm that as you're operating, the screen is actually telling you your margin. So as you're putting down your stapler, it's actually telling you you have a 1.4 centimeter margin. So that way you can make real-time decisions as you're moving your hand to lay down your stapler. And did we get it? So the first lesion, yes, we got it. Good margin. Second lesion, yes, we got it. Negative margins. And true enough, this was a 9mm lesion. And that second lesion was a 5mm additional stage 1A. So just, I have a couple minutes, so I'm going to finish really quickly. I just want to give you a taste of the future. I promised, actually, Rob, that I would give you a taste of the future. What's to come? What's the future? So I'm going to brainstorm with you a little bit, tell you a little bit of the things we're working on in our lab. So endoscopy. So there's 3 million endoscopies that are done each year for colonoscopy, colon polyps. All of you have probably had a colonoscopy at some point, and we do a lot of bronchoscopy. Here's somebody, they are doing a bronchoscopy. They have a lesion. Typically what happens is, I'm going to actually back up for a second so we don't miss this. Typically what happens is a bronchoscopist goes down, they put a needle, and they do 6 passes, and then they know 3 days later if they got cancer or not cancer. That is not, and how many times do you send somebody for EBUS and the IP says it was clean, and you're like, there's no way it was clean. That thing is so PET positive. There's something there. So this is the way we want to change the way EBUS is performed in the US. And this is applying to colonoscopy as well. So you put your needle, and this is what you see. There's no cancer cells there. Now you readjust your needle. Just a little bit of adjustment. There, you got cancer cells. So now, instead of making 6 random passes, you make a very precise decision where to make your pass, where to collect cancer cells, and you can avoid this 72-hour false negative rate. Staple lines. So as I mentioned, we now have the ability to see 1,000 cancer cells at the staple line. We've developed a wand, so we can take the wand, you take out your wedge or your staple, your parenchyma, and you just take your wand on the staple line, and you can tell if there's any cancer cells left behind. Watch this mouse. This mouse has what looks like a clean resection, and boom, right there, you left cancer cells there. So as you go around, you just go through the staple line and you can do this. We can also do this called specimen mapping. We now have a ability, like I mentioned, we have this positive margin. We've developed a box. So this, you take your specimen before you send it to pathology, you put it in this box, and this box rotates the specimen, the lobe, the specimen, liver, pancreas, whatever you're doing, and it can tell you in 3D reconstruction what is the distance from the brightest spot to the staple line. So you have a real-time information on your margin distance before you leave the OR. And AI, I mentioned one of the problems. So one of the problems we're dealing with, well, two problems I said. One is depth of penetration, the ability to see how deep, and two is that it's optical. So the problem with optical is you're still limited by a 2D plane, unlike radiology where you got a 3D image, you have a 2D image. So if you think about this, what am I looking at? I'm actually just looking at a 2D image on a screen. So we're now using technology that will create 3D reconstructions in the OR. So as you're looking at this, you can flip to a view which will give you a 3D reconstruction, and it will eventually be able to tell you what is your depth that you should be thinking about. How far does this lesion extend below the surface? So, and then finally, robotics, you know, that we've got to get to the point in our profession where we can do this robotically. It's not going to work if you have to continue to depend on VATS and laparoscopy, because the field has moved so far in this direction. So I hope we got a sense of what intraoperative molecular imaging is. I think it's applicable to all aspects of cancer imaging. I encourage somebody to be the champion of this here at University of Colorado. We're just at the tip of the iceberg. There's so much more that still has to be done. I mean, we're just literally starting the field. In 1998, Brian Wilson, he's a very famous physicist from University of Toronto. He said a controversial but recurring concept is that of optical biopsy. He used to call it optical biopsy. We call it intraoperative molecular imaging. The diagnosis based on just visualization, optical measurements, is probably unachievable. And here we are 25 years later, making this a reality. So this is my lab group who has done all the work over the years. This is our thoracic surgery group, and this is our entire division. So thank you for inviting me. It's really an honor to be here at University of Colorado, and I'm open to questions. That's sure.
Dr. Singhal, first of all, congratulations. I think you've presented a small part of your huge body of work, and this is really pushing the field forward. So 2 questions. Number one is you found a lot of incidental lesions on the surface, but there must be incidental lesions deep in the lung too. And so are we under-treating a lot of our patients? You know, we think these patients have a small isolated lesion somewhere in the periphery, but a lot of them actually have deeper lesions in the lung that are occult. So that's number one. Number two is, what about using this technology preoperatively when you're working up the patient? Is there a way to incorporate it into a PET-like scan?
Yeah.
So that is more sensitive than a PET scan per se?
Yeah, those are great questions. That's exactly what we think about. So the first one, you know, when you are operating on something at the surface, whether it's a liver resection or lung, if it's within the first 2 centimeters, you're going to be doing a limited resection. And so, yes, you're going to detect other stuff. When it's deeper than 2 centimeters, in the lung, we're doing a lobe. We're doing a total lobe. And it's not uncommon when we do a total lobe that you'll get a report back that there was another stage 1A incidentally found. So we know that's true. That shouldn't be a surprise. The problem, I think, so we have to be stewards of this technology. And you know, I remember when gene therapy came out and then genomics, everybody's like, oh, we're going to cure everything. You can't cure everything. What this is really going to help is for those really precise, limited operations where you're going to want to take out that area. You're assuming the rest is clean, but you're going to turn on your camera and you're going to find other areas. Absolutely. We all know that. We all have lesions where we take an hour, we're following a patient 3-4 years later, and they come back with other lesions. That lesion was already there. It just wasn't big enough. The second, to answer your second question, so remember a couple things. One, this is optical, so we can't see through the skin. So now you could say, well, hook it up to a PET tracer. PET's only detectable when it really gets to the 6, 7, 8 millimeters. It's not going to detect something less than 1 millimeter. Once you get to 8 millimeter, you're always going to start to see it on CAT scan. And then the other thing is you're depending on the FDG avidity of it. So it may not fluoresce anyway. So, and then the other thing is, I really don't, there are other groups working on this. They're working on optical PET tracers. I really don't want to wear lead in the OR. That's one thing I've decided. I just want to do optical. This is going to be really simple. And I definitely think simple. And actually, I have an institute at Penn that's called the Center for Precision Surgery. And actually, one of our guidelines is we will not work with PET tracers. This is meant to be simple for surgeons, inject a tracer, visualize it, and take that technology forward. But, breast surgeons are doing things like that with the armpits, so.
Well, outstanding work. Really exciting to see it, and congratulations and thanks for joining us. Can you comment on the ability to light up lymph nodes and concern for positive lymph nodes? I've seen some of your work in that. It's really fascinating.
Yeah, we're struggling with lymph nodes for a couple of reasons. One, so lymph nodes, small cells, lymphocytes, big nuclei, so it absorbs a lot of light. Black is the worst color for us. It absorbs light. And so we tend to miss a few micrometastatic deposits. If it's bigger, you're picking it up on PET scan. We're not that much better than PET scan. And we also get a lot of false positives because one of the other problems we found is for some of these tracers, if you wait 2 days, it goes into the adenocarcinoma, but then it passively starts to drain, kind of like sentinel lymph node, into the first draining lymph node. So we have a high rate of false positives, so solutions. So actually, that's the current grant I just put in to the NIH is we have a new tracer. It's going to be very specific for positive lymph nodes to differentiate positive and negative lymph nodes. We can detect with a wand 1 cancer cell in a lymph node. We're doing this for breast cancer. We're actually not doing this in lung cancer because I think that's where the biggest need is because lymphedema is just such a devastating problem. So the lymph node story, invite me back in 20 years and I'll tell you where we're at because it takes a while. There's a lot of iterations you got to go through. But actually, that's to me the most exciting question now is lymph nodes. Dr. Cleveland.
Thanks, Dr. Singhal. That was a fantastic talk. And as Rich said, I know you put a lifetime of work in 40 minutes. It's great. My question has to do with the regulatory and insurance market. If you faced any pushback from carriers about using this technology, you pointed out that as opposed to antibodies, it's pretty inexpensive, but we see in the world that sometimes necessary is not sufficient and all this language insurance companies use. So have you faced any of that problem?
Yeah, this is I actually have a whole talk just on this, but I'll give you some 2 or 3 highlights. So first of all, when cardiologists, for example, do an operation, a cath, they can't bill for giving the infusion. But what they do bill for is when you dictate in your op note that I personally reviewed the catheterization films during the case, saw a 70% lesion placed or 90% lesion placed a stent. So you can, if you dictate in your op note that you use that as part of your procedure, you would be able to theoretically bill for that interpretation of the images. So not for doing the procedure, but the interpretation of the images like a radiologist. That's coming. The second thing is you do get reimbursed for this. So roughly, and the striker reps are here, they can tell me you get billed, it's $4,800 at our institution, and you get $2,300 back for the procedure, for doing fluorescence guided surgery. So because the outcomes from the phase 3 were so promising.
Any other questions? Well, Sunil, that was a terrific talk, and we really appreciate you coming and sharing with us. The day is not over. We have a debate up in AO1 on the 6th floor, followed by several case presentations, and then Dr. Singhal will come to the Thoracic Oncology Tumor Board. And our multidisciplinary conference. So terrific.
Okay, thanks.
We have a few goodies for you. They're back here behind me. And then I know some things have been sent to you in the mail. So thanks again.
Thank you.